I would like to welcome Professor Cindy Neuzillet. She is the head of GI Oncology at Curie Institute in Paris, in France. She's also leading several clinical trials in the field of pancreatic cancer. And she has also her research team working on pancreatic cancer, tumor microenvironment. She's working especially on the interaction between immune cells, between fibroblasts. She's working also on intratumor microbiota. And she's also the past president of the French Association for Pancreatic Cancer and actual co-chair of 𝐃.𝐃 Pancreatic Task Force. So it is really a pleasure to welcome you, Cindy, and we are happy that we can listen to your talk.
Many thanks, Ingrid. Good afternoon, everyone. Thank you for the invitation and for the kind introduction. I'm going to share my screen. Can you see the slides?
Perfectly.
Okay. Thank you. So yes, so for the next 30 minutes, we will be talking about new treatment options for pancreatic cancer. So of course, I couldn't talk about everything. So I selected some hot topics with also the aim of sharing with you the French perspective in terms of research, which clinical trials we are developing in this setting. So here are my disclosures. So first, to remind you that pancreatic cancer is clearly a public health concern in all European countries, particularly in France, where the number of new cases per year has doubled in men since the 1980s, and with a threefold increase in women. This epidemiological evolution is not fully explained by the classical risk factor of pancreatic cancer. Of course, there are some modifiable risk factors, such as tobacco smoking, obesity, diabetes, on which we can act in prevention to reduce the rate of pancreatic cancer. There is also part of the increase which is related to population aging, but this doesn't explain the increase we see in younger patients, particularly in patients under the age of 50. You know, at EORTC, we have this group for young, early onset cancer, and it's something that is very of concerns. There are several directions that are explored. We don't have yet truly established causal link between environmental factors and the higher risk of developing pancreatic cancer. But for example, in France, there is a gastroenterologist called Mathias Brugel, who showed nicely that there was a correlation between the spreading of pesticides and the number of new cases in the different areas of France. So we still need to have mechanistic studies to truly demonstrate the causality, but I think we should not hide behind the known risk factors. We should also have a look at the emerging risk factors for pancreatic cancer. So when we look now at the therapeutic options for these patients, it was just to have a short overview about the different stages and distribution, but you all know very well that most PDAC patients are diagnosed at an advanced stage, particularly a metastatic stage, that surgery only applies to patients with non-metastatic disease and particularly localized disease, that surgery is not enough to cure patients even with localized pancreatic cancer, and it has to be associated with chemotherapy in all patients because all of them are virtually micrometastatic and they need to have chemotherapy in addition to surgery. That for all stages, chemotherapy with FOLFIRINOX showed better outcome than gemcitabine, either on PFS or OS or both. So it's the preferred regimen in fit patients. That radiation therapy is considered more in patients with borderline or locally advanced disease, but in locally advanced disease, it doesn't bring better survival to patients, but it allows having a chemo break after induction chemotherapy. And for borderline patients, prior to surgery, the role of chemo radiation therapy has been a little bit reduced following the results of the PANDA PRODIGE trials that has been presented last year at ESMO, showing that after FOLFIRINOX induction chemotherapy, adding 50 gray with capecitabine radiation therapy didn't improve outcome for patients. But radiation therapy still has a role that is explored for locally advanced patients, particularly with the new radiation modalities that we have, such as SBRT, proton therapy, and radiation therapy overall aiming to deliver a higher dose, a potentially cytotoxic dose of radiation, because we know that pancreatic cancer is highly radioresistant. And the last point is about supportive care. We will say a word about this at the end. That applies, of course, to all patients. And we should not forget the importance of supportive care for this patient. It's as much important as the specific treatment in order to make sure that all patients have the best quality of life and survival possible. But as you see, and as we will see later, in the presentation, the role for targeted therapy before the era of KRAS inhibitors was very limited, less than 10% of the patients, and immune therapy so far has not changed the prognosis of these patients. So I just wanted to have a quick look at the guidelines and to also discuss with you the updated ESMO guidelines that has just been released. So I think it was good to talk about this during this talk. So this is the previous version of the ESMO guidelines, the 2023 version. And as you know, all the practice in pancreatic cancer is based only on a limited number of positive trials that we have. So in the first line setting, we have the PRODIGE 4 trials that showed the superiority of FOLFIRINOX over gemcitabine in 2011. And following that, in 2013, the MPAC study showed the superiority of GemNab over gemcitabine alone. So these two regimens are considered as standard first-line treatment for patients. Even if for nab-paclitaxel there could be some differences between countries in terms of reimbursement. And for example, in France, it's not available for patients in the first-line setting. And for the second-line setting, there is also a limited number of trials to know. We have two trials with FOLFOX versus 5-FU after first-line gemcitabine with contradictory results. So one was in favor of the doublet of oxaliplatin plus 5-FU, and the other one was in the other direction, but with high toxicity rate of the FOLFOX combination, which is not what we see in routine practice. So that's why FOLFOX is still considered as an alternative in the second line setting after GEM first-line regimen. But the level of evidence is higher for the NALIRI plus 5-FU combination based on the NAPOLI-1 trial. So it was a phase 3 trial, also after gemcitabine first-line chemotherapy, and that was clearly positive in favor of the combination. But here again, we also have reimbursement issues. And in France, for example, NALIRI is not reimbursed in the second-line setting in pancreatic cancer patients. So there is the reference, but there is also the practice. And for example, we know that in the pivotal clinical trial, it was full dose FOLFIRINOX that was used. So with a 5-FU bolus and 180 milligram per meter square of irinotecan. But we know that this full dose regimen is associated with a high rate of hematologic toxicity and GI toxicity. And that's why it's very frequently used in the practice to reduce the dose intensity of this regimen, either by removing the 5-FU bolus and or decreasing the dose of irinotecan preferentially. And so there is not so many articles about this evaluation of the modified, the so-called modified FOLFIRINOX, but I wanted to share with you this meta-analysis that I found in which they gathered all the different modified FOLFIRINOX regimen. One weakness is that they found 12 different ways to adapt the FOLFIRINOX, but the conclusion was that in the studies that were comparative, there were only 3 comparative studies. The OS and the PFS was quite similar between full dose and modified, but in terms of toxicity, modified FOLFIRINOX was associated with reduced incidence of febrile neutropenia, and so that's why in routine practice it's an option, a validated option to adjust the dosage of FOLFIRINOX. Another point to deal with the toxicity is to use maintenance therapy, because as you know, FOLFIRINOX and also GEMNAB have cumulative toxicity, particularly in neuropathy. And so it's difficult to go over 8 cycles or more of oxaliplatin. So in France, it's very frequent that we decrease the dose intensity of FOLFIRINOX to FOLFIRI or 5-FU alone after 8 cycles of FOLFIRINOX. Is based on the results of the PRODIGE PanOptimox trial, which was a non-comparative trial, but the outcomes in terms of overall survival of the patient were pretty similar between maintenance 5-FU or continuation of FOLFIRINOX until progression. There is also, for the specific subsets of patients with germline BRCA mutation, we will talk about this later during the targeted therapy chapter, but there is the possibility to use olaparib as a maintenance therapy based on the POLO phase 3 trial. And for gem-based regimen, we don't have so-called maintenance therapy trial, but there are the results from the Alpaca trial, which was an alternating drug regimen in which patients received 1 cycle of gemcitabine, 1 cycle of GEMNAB, etc., in order to reduce the rate of cumulative neuropathy. And in this study, the overall survival of patients here again was pretty similar between both groups. So it's just to mention that in metastatic patients, we should not continue the full regimen until intolerable toxicity. It's better for the quality of life of patients to think about removing the drugs that induce particularly neuropathy. So what appeared since this ESMO 2023 guidelines? There have been the publication of the Napoli 3 trial. So in the first line setting with the NALIRIFOX combination regimen that showed superiority over GEMNAB paclitaxel. So we don't have the upfront comparison of FOLFIRINOX versus GEMNAB, but we have this comparison of NALIRIFOX versus GEMNAB. It was superior both in terms of OS and PFS, with a specific toxicity profile with diarrhea, particularly of grade 3-4, that represented up to 20% of patients. But there is probably a learning curve about the use of loperamide, etc., to better manage the diarrhea in this patient. But these results led to an approval of the drug at the European level. And for example, in France, they are very close to get the reimbursement. So it was negative for the second line setting, but maybe it will be positive to have access in the first line based on the results of this study. So as we said, we don't have direct comparison of FOLFIRINOX versus GEMNAB, but we have meta-analysis pulling together the different studies. And what we see in this meta-analysis is that the overall survival and PFS of NALIRIFOX and FOLFIRINOX are very close one to another and better than GEMNAB. And so that's why, based on this kind of meta-analysis, it supports the use of triplet chemo, either FOLFIRINOX and NALIRIFOX, rather than GEMNAB in fit patients. So previously, GEMNAB was at the same level as FOLFIRINOX, but based on the results, triplet chemo now appears over in terms of level of evidence than GEMNAB. In terms of toxicity profile, when you compare NALIRIFOX to FOLFIRINOX, there are more diarrhea with NALIRIFOX, but less peripheral neuropathy because the dose of oxaliplatin is reduced to 60 milligram per meter square in this regimen, as opposed to the 85 milligram per meter square that we have in the classical FOLFIRINOX. There were also this other Bayesian meta-analysis in which they included not only GEM-NAB, FOLFIRINOX, NALIRIFOX, but also other regimens such as the Italian PAX-G regimen or the alternating sequence regimen presented by Alfredo at ASCO and then later published. Alternating FOLFOX with GEM-NAB. And in this meta-analysis, the important message is that here again, triplet chemo do better than GEM-NAB. There was a trend for NALIRIFOX to be a little bit more active than FOLFIRINOX, but it's only it's not a true direct comparison, and it's not significant. So I think we don't have enough level of evidence to prefer one versus another. Also, given the economic cost of NALIRI. So if in your country you don't have access to NALIRI, I think it's not a fault to use FOLFIRINOX. The other evolution we had in the guidelines was in the second line setting with the GEM-PAX trials, which was a French trial. So as I said, in France, we don't have access to nab-paclitaxel. So we use what we call the nab-paclitaxel of the poor. So it's paclitaxel, the simple paclitaxel, in combination with gemcitabine in the second line setting. So we didn't have so far clinical trial after FOLFIRINOX. And so in this trial, they enrolled patients in second line after FOLFIRINOX, and they randomized them between gemcitabine alone or gemcitabine plus classical paclitaxel. So the results of this study are contrasted. So you can use them in one way or another, because you add a benefit on PFS and also on overall response rate, but no effect on overall survival. So you might say either, as I have no effect on overall survival, I prefer preserving the quality of life of my patient and doing GEM alone and then paclitaxel alone at disease progression. Or you can also say, if my patient is symptomatic or is young and particularly fit, I want to have a rapid effect on the symptom, and I will use the combination of GEM plus paclitaxel first, and I can have a maintenance treatment with GEM alone after a treatment phase with the combination. So based on these results, there is no clear preference for one regimen or another. It really depends on the type of patient you have in front of you, the fragility of the patient and the symptoms of the patient. So that's the updated guidelines from the ESMO. So as you see, what is new is that now we have the MCBS score for each drug. You have NALIRIFOX that is part of the strategy, so for the first line regimen. And for the second line regimen, we have no GEM-paclitaxel that has been added following the results of the GEM-PAX trial. So that's where we are in terms of therapeutic landscape. And now I wanted to focus on a few tracks in order to improve patient outcome. So the first one, and it was also something that was discussed at the last ASCO meeting, is to make better use of available chemo drug. So trying to use molecular information from the patient in order to prefer FOLFIRINOX versus GEM-NAB in the patient. So as you know, in terms of transcriptomic signature, they are the classical and basal subgroup that have been described a few years ago now. They have some surrogates such as GATA6, immunohistochemistry, or ISH, that could be a predictor of the RNA subtype. And at the last ASCO meeting, it has been showed that using GATA6, for example, we can identify basal-like tumor, even if it's not a perfect correlation. And basal-like tumors seem to be more resistant to FOLFIRINOX, but we don't know exactly with what we should treat them, because they also have poor outcomes with gemcitabine-based chemotherapy. So this is the first way of using prediction, is with the basal classical subtype. In France, we have another approach, which is to use chemo drug-based signature. So it's from our colleague at Marseille, where they use different patient-derived model, so either primary cell cultures, organoids, or PDX, and they treated the different models with each of the drugs we use in the clinical practice. So GEM, paclitaxel, 5-FU, irinotecan, oxaliplatin. So they first published their results about the gemcitabine prediction signature, the 𝐃.𝐃 signature, that they used both in the metastatic and the adjuvant setting, and they showed that patients with a 𝐃.𝐃 positive signature had a better prognosis and response to GEM-based chemotherapy than patients with a 𝐃.𝐃 negative signature. And they also transposed this principle to other chemo drugs, so for the drug of the FOLFIRINOX combination. These results were used retrospectively on clinical trials or data set of patients. And now we are moving to the phase of clinical validation in prospective trial. And so we are currently leading in France, for example, the PACSIGN trial, in which for patients with metastatic pancreatic cancer, we use this chemo prediction test in order to select the chemotherapy regimen between either FOLFIRINOX or gem-nab-paclitaxel in the patient to see whether this algorithm can provide benefit to patients in a prospective fashion. So this is for metastatic patients, but we also have a large national trial in the borderline setting, so-called the NeoPredict project, in which they use the 𝐃.𝐃 signature in order to give patients either GEM-based neoadjuvant chemotherapy or FOLFIRINOX neoadjuvant chemotherapy. So with this idea that we think that patients who are GEM sensitive will not do better than FOLFIRINOX when you give them gemcitabine, but they will have less side effects than with FOLFIRINOX. So the idea is not to have truly a superiority, but more to have the same outcome with reduced toxicity. So this is for the RNA prediction. Another approach is also to use organoids as a surrogate of patient response. So there are several clinical trials ongoing in Europe using organoid as patient's avatar. In France, our colleagues from Gustave Roussy have a program in which they published the first results. The problem we have so far with organoids is still the turnaround time, because it's around 7 to 8 weeks in order to have the organoid ready for drug testing. And in the meantime, you can't leave your patient without any chemotherapy. And so what we see is that the organoid is pretty good to predict the sensitivity to the drug the patient is receiving while you're making your organoid, but it's not very good at predicting the sensitivity to the drug after this treatment line. So there is this problem. And so in order to overcome this, we will need to have a shorter turnaround time for organoids. It's clearly a limitation. So this was for the first track. The second track is to have new therapeutic targets for patients. And so in this context, we have to also take lessons from the past, because when we tried previously to develop a targeted therapy, they were given to all comers patients without molecular selection, and that led to plenty of negative clinical trials, so with no benefit for pancreatic cancer patients. And the progress were made when we started defining subgroup of patients based on molecular alteration and matching specific drugs with specific molecular alteration. So the one that has been validated first was germline BRCA1 and BRCA2 mutation, as we said before, with the use of olaparib as maintenance treatment after a chemotherapy induction phase with platinum. We know that there is no benefit to combine from the very beginning the PARP inhibitor with the platinum-based chemotherapy. The trial in this evaluating this strategy was negative. And we also know from recent clinical results that PARP inhibitors have no clinical effect in patients with non-germline mutation, so with somatic alteration. We had a trial in France directed by Pascal Hamel, but also other trials that showed that the clinical benefit is limited compared to patients with germline alteration. But how can we move forward in this patient? We can go beyond PARP inhibitors toward combination of PARP inhibitors with, for example, immune therapy. That's what was tested in the POLAR trial from our colleagues in the MSKCC, showing in the maintenance setting very interesting overall response rates of 35%. So probably there is a role for this new combination, even if they are not ready yet for the prime time, for the clinical routine. But it's something that could improve the outcomes, because we know that even patients with BRCA germline alteration, about 1/3 of them are resistant to PARP inhibitors. So we can improve the outcome of this patient with these new strategies. Speaking again about immune therapy, the role for immune therapy in PDAC exists, even if it's very limited, but we have to think about checkpoint inhibitor in patients with MSI, deficient MMR, pancreatic cancer. It's something that is very rare, that need to be confirmed by both immunohistochemistry and PCR to make sure that we have a true MSI patient and not a false positive MSI patient. But when patients are well selected, we clearly see very impressive outcome in this patient with PFS of more than 2 years, median OS not reached in this larger observational European cohort. And so it's truly something easy to look at and that we need to search in the clinical practice. Another interesting point is to look deeper into KRAS wild-type patients. So that's why I think now in our routine practice, we truly need to have a KRAS status for all our patients, both for KRAS inhibition, but also for looking to larger NGS panel in patients who have no KRAS mutation, because these patients, they don't have the classical driver of carcinogenesis, which is KRAS mutation. So their tumor rely on other alteration for their progression, and this alteration can be druggable. We know that it's associated to sensitivity to anti-EGFR. These RAS wild-type patients are overrepresented among young patients and also among acinar cell carcinoma subtype of pancreatic cancer. And they can display BRAF alterations and also several types of gene fusions, which are mutually exclusive with KRAS mutation. And particularly, we had at the beginning of the year a New England in the field of pancreatic cancer with zenocutuzumab and in NRG1 positive patients showing overall response rate of 40% with long-lasting response in these patients with NRG1 fusion. So that's why when we look at clinical registries about the clinical input of NGS and targeted therapy in pancreatic cancer, there is clearly a clinical benefit when patients with a targetable alteration receive the match therapy. But when you look in the details of the drugs that are used and the targeted alteration, it's mainly based on MSI, BRCA/NES, and fusions or BRAF mutation in patients who are RAS wild-type. So that's why I think the minimal package we need to have in all our patients are the search for these 3 molecular alterations. And now, as we said, there is this change in the paradigm of PDAC treatment, which is the targeting of KRAS mutations that we found in 90% of PDAC. For several decades, we have tried to target KRAS, but it was negative in the different trials using farnesyl transferase inhibitors or MEK or RAF inhibitor combination. And the story began with the targeting of KRAS G12C in lung cancer, in colorectal cancer, but also in a small subset, 1 to 2% of pancreatic cancer, with quite interesting response rate, even if it was short-lasting responses in most patients, probably requiring combination therapy of these RAS inhibitors. And what is currently under the spotlight is the targeting of KRAS using pan-RAS inhibitors or G12D inhibitors, for example, particularly in the second-line setting with a phase 3 trial ongoing. That clearly brings interesting survival outcomes and response rates in this patient when we compare it to classical second-line chemotherapy. So we need to have a comparative trial, which is ongoing, and see whether it can change our practice. Among the other pathways that are being explored, there is also MTAP deficiency. So MTAP is a gene located very closely to CDKN2A. So we know that the loss of P16, so encoded by CDKN2A, is something quite frequent in pancreatic cancer. And when there is a deletion of this zone, the deficiency into MTAP make the cancer cells sensitive with a synthetic lethality concept to the targeting of PRMT5. So PRMT5 is a multiple function protein involved in the methionine metabolism. And so when you inhibit MTAP in these cells, you can induce PRMT5, in these cells, you can induce cell death by lethality synthesis. So this is currently under investigation in several clinical trials, and I think we should keep an eye over these drugs in the next year. The other potential therapeutic target is also the intratumor microbiota. As you said in the beginning, Ingrid, it's a new player in the pancreatic cancer microenvironment. We know that there are bacteria in these tumors, that they play a biological role, and that patients who are exposed to antibiotic and gemcitabine chemotherapy at the same time seems to have better prognosis, maybe because some bacteria within the tumor produce CDA, so the enzyme degrading gemcitabine, so interacting with the metabolism of the drug. So that's why in France we have a large phase 2 randomized trial that is going to start in the next week. It has just been approved by the European authorities. So in which we ask two questions. The first one is in the first line setting, the use of 5-FU maintenance with NALIRIFOX background, so the same as Panoptimox, but with NALIRIFOX instead of FOLFIRINOX. And in the second line setting, the role of microbiota targeting using antibiotics in combination with gem-based chemotherapy in order to bring an answer to this question, because it seems counterintuitive that antibiotic can be something bringing better outcome in our patients. So that's why we want to have a prospective study to answer this question. The third track is also to rethink the immunotherapy development in this patient. So far, all the results of classical immune checkpoint inhibitors in PDAC have been negative, either as a double checkpoint inhibitor combination in advanced patient after chemotherapy progression, or in combination with chemotherapy in the first line setting. So this is due to the unfavorable immunosuppressive microenvironment of pancreatic cancer. And so we need to have new approaches, both in terms of a type of therapeutic agent and also of setting for developing this drug. Obviously, patients with metastatic disease in a disease progression context are not the good one to give a chance to immunotherapy to show an effect. So as you know, there are different vaccine trials that have been published. The results we have so far are limited to single-arm studies without a comparator arm in the adjuvant setting. So we are not talking about the metastatic setting, but patients after surgery usually after completing as well the chemotherapy, the adjuvant chemotherapy, who will receive the vaccine approach with either a personalized approach, mRNA vaccine designed from the tumor, but it takes 8 to 10 weeks to build the vaccine for each patient, or off-the-shelf approaches targeting KRAS. Both of them showed immunogenicity, but we don't have so far the demonstration of the clinical benefit of this agent. For that, we need to have the results of the randomized trial versus the standard treatment of these patients, so versus adjuvant FOLFIRINOX, to be clear. Because the problem with this single-arm trial is that we are looking at very selected patient population, and we don't know exactly what is the survival outcome in this selected patient population. And when you look just at a single-arm trial, you can get too much enthusiastic too quickly. So the same for CD40 agonists. They showed very interesting effects in combination with FOLFIRINOX in the metastatic setting, in the first-line metastatic setting. But here again, probably they will not be further developed in all comers, but they are looking at specific predictive biomarker to find a companion biomarker for the further development of this drug. And we still need to have a comparative study in order to clearly evaluate the benefit of this drug. Why do I insist on these points? Because on a certain manner, we were confronted to this aspect of the control arm in the TEDOPAM trial that we presented at the ASCO a few days ago. So in this trial, we used the off-the-shelf peptidic vaccine in patients with metastatic PDAC in a maintenance setting. So as we said, it's not good to give a vaccine in patients who are with disease progression. So we selected patients by the fact that they had controlled disease after 4 months of induction FOLFIRINOX, and we randomized them between FOLFIRI or FOLFIRI plus the vaccine. We didn't have any prospective trial in this specific subset of patients who had already been controlled with FOLFIRINOX. So we just had some observational cohort with a limited number of patients where the median overall survival of these patients from the start of the maintenance was around 10 to 12 months. So that's why we defined our statistical hypothesis with a positive trial if we observed more than 50% of patients alive at 1 year. And our trial was clearly positive, with 65% of patients alive at 1 year in the experimental arm, but the control arm in this non-comparative trial also did very well, with 17 months of overall survival in median in patients just receiving FOLFIRI. So if we had done only a trial with the experimental arm, we would have think, yes, miracle, we will save PDAC patients with our vaccine and we should go for a phase 3 trial in all comers. And so it shows you the importance of having a control arm, even if this early trial, in order to evaluate properly the benefit of this approach. And also we will try to get as much information as we can from this trial through a vast ancillary program that has been funded by an academic grant in France in order to look at the blood, the tumor samples, and the imaging of this patient to try to define which patient could be responders to this vaccine approach versus the patients who don't benefit from them. And finally, we should not forget the importance of supportive care of these patients, particularly the superpower of physical activity. At the ASCO, there was a presentation of a challenge trial in the adjuvant setting of colorectal cancer, showing that adaptive physical activity bring an overall survival benefit that is of the same magnitude as chemotherapy. So it's truly something important. And in the pancreatic cancer setting, we led the APACAP trial a few years ago in patients with metastatic pancreatic cancer, in which we showed that adapted physical activity was something that can improve the quality of life of our patient by delaying the time until definitive deterioration of quality of life, and also improving several symptoms such as pain, decreased appetite, or fatigue in our patient. And so now physical activity is also used at earlier stage within rehabilitation program, in which it's combined with nutrition, with psychological support, in order to prepare a patient for surgery. So the pop-up trial is the one that is ongoing in France, but in the Netherlands, for example, they have the biggest trial ongoing on this topic, with more than 2,500 patients that will be enrolled. So it will be clearly the challenge trial for pancreatic cancer. And these results, we hope, will help change the mentality of our colleagues to have a better look at this approach. And as we said, exercise has also other biological effects, and particularly there are very nice research papers showing that it can increase the immunity both at the systemic and the tumor level. So in other tumors than PDAC, it's where we can see first trials emerging in which physical activity is combined with immunotherapy administration, for example, in order to try to enhance the effect of immune therapy. And as you know, there is also pharmacological development of agents targeting the pathways involved in malnutrition, in cachexia, such as the ponsegromab for the targeting of GDF15, that was also published in a New England article a few months ago. So I think I will move straight to my last slide to say that I think for this future perspective of pancreatic cancer, we are clearly moving toward this multi-scale integrated approach for the treatment, with both the better definition of the molecular profile of our patient. So with, as we said, a minimal subset of BRCA, KRAS, and MMR screenings that should be done in all patients. Future approaches with RNA chemogram or organoid that may help better use the different drugs we have. For the tumor microenvironment, new agents, so other agents than classical checkpoint inhibitor. I told you about CD40 agonist, about vaccine. At ASCO, there was also first results about CCR8 inhibition. There is also plenty of research trying to target cancer-associated fibroblasts. And the targeting of intratumor microbiota is still in the early years. I think we need to have more mature approach. Antibiotics are clearly dirty approaches, and we need to develop more targeted approach for the microbiota TME interactions. And finally, taking care of the host with all the different side effects and complications related to the tumors is something very important if we want to bring our patient in the best condition with the optimal quality of life and survival. So with that, I thank you for your attention, and I will be happy to take your questions.
Thank you very much, Cindy, for your question. It was really very clear and really very nice. So are there any questions for Cindy? Yes?
Yeah, one quick question. When you spoke at the beginning about radiotherapy and it was a negative trial, I guess then they didn't do any molecular profiling, and it was in these patients. So maybe if you add the molecular profile, with it being a clinical trial, I don't know if there's a possibility to go back to these patients, get the logs from pathology and do so, because it's unfortunate that it's a lot of negative trials, but then it's still a lot of information and still a lot of samples available to be able to address these issues that you brought up with KRAS, positivity, negativity, BRCAs, things like this. So I don't know, maybe as a community in pancreas cancer, there should be some kind of effort to take more advantage of these clinical trials, because they're large trials, a lot of money, a lot of patients, and probably we could still make more of them, even though they're negative.
I totally agree with you. Clearly, I think that in locally advanced pancreatic cancer patient, the fact that we see no effect is probably because it's diluted among we don't manage to identify the right patient. There was this trial from the American group in which they aimed to assess the SMAD4 status. SMAD4 inactivation is associated with metastatic spread, and so they hoped to see something, but the trial was stopped in the middle of the accrual, unfortunately. But it's clear that now we have more interesting signatures than SMAD4 only. With the basal subtype, for example, I do think that patients with a basal subtype probably are not good candidates for radiation therapy. The issue we have is that indeed when trials are positive, are negative, usually people don't look deeper into the ancillary studies because it's difficult to find money in that case to fund the ancillary programs. That's what we anticipate for the immune therapy trial, and we truly wanted to take the advantage of this trial to ask questions, biological questions, even if it was negative. But also the other issue that we have for a locally advanced patient is that the samples available as they are endoscopic US samples, they are sometimes too limited in order to have enough material. There is enough material to make the diagnosis of PDAC, but not enough to make the molecular assay for this patient. But clearly, I think that our role as academic researcher is to put everyone together and say we should put our samples together and try to see whether we can identify a molecular subset of patients that benefit from this approach of radiation therapy. You're muted, Julie, sorry.
Oh, thank you. I was just saying it's high quality data, high quality, with clinical trials, so it would be a shame. But thank you, Cindy. It was a great talk. Really good. Thank you. Thanks a lot.
Thank you.
Okay, so we have another question.
Hi, I'm Bhavna. I'm a PhD student in Faculty of Medicine in Pilsen. And I have a question about the metabolism. Like, Cindy, is it possible to have this control in diet along with the therapy that you're giving, like restricting the glucose or fructose, like that? Is it possible in pancreatic cancer, for pancreatic cancer?
So,
or at least have we tried in patients?
So thanks for this question, because it's a very important point. And during our visits with the patient, we clearly talk with them about this, because it's a big issue, because they see in the journal articles saying that cancers eat glucose and that they should remove glucose from their alimentation in order to make the treatment more efficient. What you need to know is that there is no human data supporting this concept, and there are some mice data, but none in pancreatic cancer model. It was in breast cancer model, and researchers, particularly in France, working on PDAC metabolism in Marseille, Sophie Vasseur teams is highly expert in this field, and she clearly showed that when you deprive PDAC cells from glucose, they use other fuel. They use ketonic acids, they use your protein from your muscle. They are highly plastic because they're developed in a very hostile microenvironment. So if you remove something, it will not make the cancer cell suffer, it will make the organism suffer. And so what we observe in our patient is that fasting is something deleterious, because it make the malnutrition worse and worse in these patients, and so they get weaker, and we have less possibility to give them treatment. So when we see them in our visits, we tell them, eat whatever you want. There is nothing forbidden. What I want is just you to keep your weight, because pancreatic cancer, most of them are cachexia. And cachexia is a specific syndrome. It's not just malnutrition. It's malnutrition plus an hypercatabolic inflammatory syndrome. So they have very high basal expenditures of energy. And so if they reduce their expenditures, their intake, either by fasting or by removing the glucose, they will lose weight very quickly. And so they will get more frail. So that's why it's something we clearly not advise in our patient. Ingrid, I don't know what is your position for that, but
in Italy, it is the first question, what I can eat. So yeah, but we have also this approach. So you can eat what you would like to. Of course, we have a nutritional support for our patients. So each patient which is affected by pancreatic cancer, but also with other GI cancers, receive nutritional support. But I absolutely agree with Cindy. So no fasting, no no other diets and everything.
Okay.
So
Yeah.
so
thank you for the
maybe in
question.
adjuvant breast cancer patient, when we have no tumor anyway, etc., that's where the clinical trials are going, but not in patients with metastatic cachectic tumors. It's not the right direction.
Okay. Thank you so much. Thank you.
You're welcome.
Thank you, Bhavana. Okay, are there any other questions for Cindy? Cindy. So I would like to again thank you very much for accepting this invitation and for your very nice presentation. And again, another question. Sorry. Go, Julie.
No, it wasn't a question. I was
No,
trying
no,
to give you a thumbs up.
no.
Thank you.
Okay. Okay, it was just for your support. Okay, so thank you so much, Cindy, really very much.